Thank you very much for meeting with us, Chief of Surgery. We are Johns Hopkins team number 20, and I'm here with Vicki Wang, and I am Dr. Lucy Yamamoto. To optimize operations at Hipkins Hospital Orthopedic Surgical Center, we recommend 5 key changes that will optimize utilization between 52 to 57% for surgeons, 74 to 76% for the anesthesia team, for a 75% improvement in optimization with 7 cases daily per surgeon. We recommend developing pooled queue modeling of 4 ORs and pooled processing, optimizing both employee experience by implementing standardization of sedation and surgical processes by maximizing support staffing with 2 nurse anesthetists and 2 PAs, implementing parallel processing with standardization to allow for the ability for faster patient arrival times, optimizing patient experience through patient information board for up-to-date status checks, and creating a pre-surgical management support system that is offered to all patients, not exclusionary to those with higher BMIs, to improve post-surgical results and prevent bad outcomes. It will also aid in preventing falls.
To provide effective optimization to the operating process for the Department of Orthopedic Surgery at Hipkins Hospital, we first took a deep dive of the existing process to look for bottlenecks and areas of improvements. Your current process employs a model where one surgeon, one anesthesiologist, and 2 ORs are assigned to each track, with the addition of 2 registrars being pooled. This model does not take the full advantage of pooling, evidenced by the relatively low surgery count that's below industry benchmark, and high utilization of both surgeons and anesthesiologists. According to a study that conducted a systematic review across multiple surgical specialties, high emotional exhaustion has been an issue. The study uncovered that more than 30% of surgeons felt exhausted, which would impact the long term sustainability of their career and well being. Additionally, your current process incurs a lengthy flow time that is over 3 hours of wait time for both patients and caregivers. This long wait time can create emotional stress and anxiety for everyone and can result in low customer satisfaction. Support staff such as registrars and cleaning crew could also be better utilized to improve overall performance for the department, both operationally and financially. With those findings in mind, we would like to share 2 optimization recommendations using the job shop model for your review and discussion. Optimization Model 1 employs a pooling process to drive efficiency and better utilization of the staff and resources. In this model, we pooled the 4 ORs, added 3 CRNAs and 2 PAs to share the workload with the surgeons and anesthesiologists, and reduced registrars to 1 to stay within the 6 staff limit. This pooling approach has significantly reduced the utilization of both surgeons and anesthesiologists, avoiding burnout and allowing them to allocate time for other patient-facing services. All other support staff are also better utilized in this model. As a result, the average flow time has reduced by 30 to 45 minutes. We also saw a near 75% increase of surgeries completed, with each surgeon doing about 7 surgeries on average per day. However, we recognize adding 3 CRNAs is a sizable financial requirement on the department. So we tested another optimization model where we reduced the CRNA to 2 and added one more registrar. We were able to achieve again, on average, 7 surgeries per surgeon per day, but in a more cost effective way. Additionally, we believe the extra cost will be justified by the numerous benefits they create. With the increase of near 75% of surgery completion, we are able to help more patients to obtain much needed orthopedic surgeries sooner and help improve their quality of life. It is also important to note that by hiring support staff such as CRNAs and PAs, we are incorporating diverse backgrounds and skill sets that is well aligned with the department's DEI goals. Next, Lisa will go into more detail on the range of benefits and the positive impacts the optimization model can create.
Thank you, Vicki. I would like to spend some time discussing pooling improvements for added flexibility and load sharing. In our current state, we have fixed OR assignments, no shared anesthesia resources, and no shared PA support. We recommend instituting 4 pooled ORs, instituting 2 floating nurse anesthetists to prepare patients for sedation and effectively shortening sedation time, using shared anesthesia pools across 4 ORs in a floating model. This will allow the first available anesthesiologist to move to the next ready patient. And on the surgery side, we recommend instituting 2 floating PAs to expedite surgery start times by interfacing with patient in pre-op area, performing site scrubs, performing surgical assistance, and preparing the patient for transfer to PACU. The expected impact of this, the presence of the 2 nurse anesthetists and surgical PAs, provide a more dynamic and nimble surgical system that will absorb pre-procedural and peri-procedural bottlenecks, decreasing surgical wait times from 30 minutes to about approximately 5 minutes. It will shorten waiting times for anesthesia prep and evaluation, but most importantly, pooling of ORs, CRNAs, and PAs provide the perfect support in the event of a perioperative event such as intraoperative cardiac event, pulmonary embolism, unanticipated intraoperative bleeding, or anesthesia event. In our current state, we have fixed anesthesia assignments, overworked anesthesiologists, and surgeons approaching capacity. Our recommendations: fully pooled ORs rather than surgeons working only on 2 assigned ORs. Working in 4 pooled allows dynamic reassignment based upon whichever OR patient is ready. Using shared anesthesia pools to reduce anesthesiologist workload, and shared PA support to reduce surgeon workload. The expected impact: reduced anesthesiologist capacity and sustainable workload for improved physical and emotional well-being. Also, freeing up surgeon capacity to spend more time consulting patients and/or caregivers. With our recommendations, we expect that the utilization rate for surgeons to be 54 to 57%. In the addition of PAs to support them will address surgeon burnout. Increasing the rate of surgeries must be weighed with the utilization rate to avoid surgeon burnout. Even though the utilization is low, this must also be weighed with what the surgeons actually do within their workday. They may be on a week of 24-hour call where they have to attend to ER referrals for surgical consults. They may have to visit patients that were admitted to the hospital for post-procedural observation, or they may have clinic hours. To give some context, according to the American Academy of Orthopedic Surgeons, on their 2025 article on onboarding, individual orthopedic surgeons are responsible for an average of $3.29 million worth of revenue per year. But when a surgeon is lost to burnout, the impact is not only the indirect costs of lost revenue, but also like indirect costs of recruitment, relocation, sign-on bonuses, marketing, and interviewing costs ranging from $250,000 to $500,000. In total, approximately $1 million to replace a surgeon due to burnout. Approximately 50% of newly trained physicians actually turn over within 2 to 3 years, and 70% within 5 years. Current issues with regard to variance reduction and standardization, we see high variability in pre-op anesthesia and recovery times, BMI-related procedural time variability, and simulation limitation for linear stepwise tasking. We recommend standardizing anesthesia and recovery protocols for nurse anesthetists by implementing standard anesthesia protocols based upon procedural type and patient risk. Using predefined protocols for total hip arthroplasties and total knee arthroplasties, for example, spinal block and sedation for average risk patients, and including BMI-based adjustments for drug dosing and monitoring. Also, we recommend standardizing the increased use of regional and neuroaxial anesthesia to reduce recovery time and complications. Using a pre-anesthesia checklist, including BMI category, ASA score, allergy history, and comorbidities, digitally integrating into EHR to flag risk cases and standardize anesthesia planning, centralizing preoperative anesthesia evaluation by assigning one CRNA or anesthesiologist to conduct batch evaluations in pre-op holding areas before the surgery begins. Post-procedural recovery protocols, just standardizing monitoring and discharge criteria based upon anesthesia type and patient status to reduce variability in recovery room time. And as far as the recommendations for the surgery side, developing procedure-specific surgical pathways, especially for both total knee arthroplasties and total hip arthroplasties, using evidence-based clinical pathways that define standard incision techniques, implant selections, and antibiotic use, even pain management protocols, and standardizing instrument trays and OR setups. Optimizing surgeon-PA collaboration by delegating routine steps, for example, like closure prepping to PAs per standard protocol, and allowing surgeons to basically begin the next case a lot sooner. Scheduling surgeries based upon BMI and complexity by placing lower variance cases earlier in the day to ensure smooth OR turnover, and group morbidly obese or complex cases in the late morning or early afternoon to avoid end-of-day overruns. And then establishing a pre-surgical optimization program by offering weight management guidance at pre-op appointments, encouraging physical therapy pre-op and post-op, and doing referrals to dietitians. Our hope is that the implementation of these variance-reducing techniques will optimize parallel processes where both sedation and surgical tasks occur simultaneously. For example, while anesthesia is sedating the patient with propofol and securing their airway using LMAs or intubation, they're also, the surgical side, they're performing catheterization, scrubbing the surgical sites, and getting the patient basically positioned for surgery. In years to come, new technology will be widely used to standardize surgical procedures like total hips and total knees, like the implementation of robotics for minimally invasive surgeries, computer navigation, and 3D printed implants, even smart sensors that will speed actual procedures. According to an article by Hospital Specialized Services in New York, they're already offering these new technologies, and they've been doing this since 2021. The expected impact, the presence of the 2 nurse anesthetists and surgical PAs provides definitely a more nimble and dynamic surgical system that will absorb peri-procedural bottlenecks. This will essentially shorten waiting times for anesthesia prep and evaluation, shorten overall procedural times. We would like to discuss the psychology of waiting and overwork, as psychology does matter. Current issues are we have long and variable waiting times, basically creating dissatisfaction and anxiety for patients and their caregivers. There's a waiting area bottleneck. We also have increased PACU pressure to interface with the patient's family members. And in this current state, this leads to staff burnout. Our recommendations is to implement a real-time tracking system to provide patient status. This can be manned by the reserve utilization by registration staff to make an impact by electronically interfacing with family members to offer small milestones or updates during long waits. We can allocate 20% of capacity from these registration staffing in combination with the PAs to keep patients and caregivers updated on progress. Utilizing the support staff will also assist surgeons and anesthesiologists. As far as expected impacts, psychology does matter in this case, and the impact of increased stress of waiting from the patient experience can make the difference of a perceived bad outcome from expected post-surgical effects of pain. Additionally, from the healthcare provider experience, the information that can be interfaced from nursing staff to the registration desk or from the PAs to the registration desk can reduce perceived wait time anxiety. Higher patient and family satisfaction is definitely can be expected, and the electronic board keeps families engaged. It improves their experience significantly, and ultimately, as far as the staff is concerned, alleviates burnout and sustains long-term well-being for all the staff members. When implementing a new strategy, it is important to perform a SWOT analysis. Hipkins' hospital optimization strategy shows the following strengths, weaknesses, opportunities, and threats. As far as strengths, fully pooled ORs enable better load balancing and reduces idle time. Dedicated 2 PAs and 2 CRNAs streamlines clinical tasks, freeing up the surgeon's time. They can perform preoperative interface before surgery. PAs, if trusted, can be first assist, can close up incision sites, perform pre-op and post-op transfers. CRNAs can start IV lines, administer pre-sedating medications like midazolam, and process standardization reduces variance, improves scheduling accuracy. One of the strengths of the recommendations is the concept of parallel processing, where portions of the tasks of anesthesia and surgery are occurring at the same time concurrently. The availability of pooled queuing of ORs and utilization of PAs and CRNAs, as well as staff, not mentioned in scenario, but occurs in real life cases like OR surgical techs, scrub nurses, allow for many of the processes to run parallel, decreasing time for turnover, adherence to surgical start times, as well as shorten the duration of procedures. Preoperative pre-surgical optimization program helps decrease surgical time, improve case outcomes, especially in more morbidly obese patients. Electronic status board improves the patient care interface, team interface, because psychology does matter. As far as weaknesses are concerned, all PAs and CRNAs are not created equal. Experience levels vary, and the ability to provide support may vary. Initial costs and complexity in implementing BMI pre-surgical programs include staffing, scheduling, patient buy-in. Once instituted, it would be a bottleneck for available operative cases. Limited data on short-term outcomes of pre-surgical optimization programs, throughput without long lead time, and then training on the operation of electronic surgical board may be challenging. Pooled resources may introduce coordination challenges and staff conflicts. And despite standardization, case complexity and teaching demands add variability. Factors like allergies to anesthetic medications and their chemical analogs, patient comorbidities like atrial fibrillation, coagulopathies, and diabetes can also add variability. Opportunities seen from our recommendations include increased efficiency and decreased variance with standardization, decreased average surgical time through parallel processing. It allows for more efficiency and decreased surgical wait times. Additionally, it gives more leeway time for intraoperative complications and complex patients, and it also improves OR turnover. Enhanced patient education and wellness with pre-surgical optimization programs improves patient satisfaction, recovery, and patient outcome. Patient status boards provide more interface and reduces patient caregiver stress. From the surgery care standpoint, it also leads to a less interrupted day. Threats include staff resistance to new roles or processes. Surgical quality may decline if pushed to high volume targets without adjusting support systems. And one thing to note is that increasing surgical utilization may not always be optimal for physician retention, because while surgeons are not in surgery, they are often performing inpatient visits for patients who have been transferred to the hospital for stabilization or observation. They may be on call, 24-hour on call, where they are addressing and assessing patients for in the emergency department for surgery. They're also performing office hours to evaluate cases for surgery and doing post-op checks. PA's support is definitely necessary to allow for surgical staff retention in this case. There could be possible equity and access issues if BMI programs delay high BMI or low compliance patients. And then continued pressures on resources like EVS and PACU if throughput is increased without system-wide scaling to handle the numbers. In conclusion, our final recommendation is to achieve optimized utilization between 52 to 57% for surgeons, 74 to 76% for anesthesia team, and have a 75% optimization of 7 cases daily per surgeon, is to implement 4 pooled ORs, deploy 2 CRNAs and PAs to provide parallel processing to improve utilization, decrease bottlenecking, and improve patient safety and patient experience, decrease variance by standardizing processes within the anesthesia and surgical process, and improve patient experience by including a digital status board that is manned and updated by a registration team. We also advise creating a pre-surgical optimization program which honors and addresses diversity, equity, and inclusion as it is offered to all patients for improved patient outcome. It is not exclusionary to those with higher BMI. It is geared to improve post-surgical outcomes, improves overall well-being, and aids in fall prevention. Thank you for your attention.